just show you that there's many approaches towards addressing or helping individuals develop immunity against the virus. Again, the goal here is protection against acquiring disease, or even if you acquire disease, to at least mitigate the severity of the disease. And again, the lead platforms have been the nucleic acid vaccines to the left, which I have been involved with the Pfizer vaccine. There's also protein and protein subunit vaccines like the Novavax and Sanofi. I'm involved with Sanofi's phase 2 program. And also whole viral vaccines. We've mentioned the inactivated viral vaccines, the China vaccines, and then the non-replicating viral vector vaccines with AstraZeneca and Johnson & Johnson being the two lead platforms with the viral vector platforms. And there's some other technologies percolating in the background that haven't quite advanced in human trials yet. So there's a lot of work going on. There's differences between, the efficacy of the vaccines, how they're delivered, requirement for cold chain, the ability to quickly produce, mass produce, adapt in the setting of new variants where you need to produce another version of a vaccine. But however, many of these have eventually proved successful for COVID-19 prevention. I know this is a scientific slide, so I'm not going to talk too much about this, but just again to mention that especially for, I guess, this is an audience, including people in low resource settings, I think cold chain definitely is a limitation for the mRNA vaccines, being able to utilize and distribute that in many of our settings. And even if there's a desire to do so, just the amount of resources that need to be poured in to set up a cold chain for just some of these vaccines, you wonder if they're worth the investment. Probably better using approaches that don't really require that. And I think that factors into why COVAX has really heavily favored vaccines like the AstraZeneca, for example, that can be kept at the fridge temperature. There are also unique considerations for different vaccines. One of the issues with viral vector vaccines, so that's the one in the middle. I should try to maybe make a pointer here so you can follow. So for this column here, one of the downsides of viral vector vaccines is anti-vector immunity. And we know in African populations, for example, that the rates of anti-vector immunity, which means that some of these viruses that are used to deliver, the genetic material for the spike protein, which is how you deliver the vaccines, that some people already have immunity to the virus that's being used, such that that can in some ways diminish the immunogenicity or the immunogenicity for the vaccine. All right, so let's start to address some of the myths that are out there. Again, I think one of the issues that always comes up is, do vaccines alter DNA? I think that's important because there's that perception around, how altering DNA can be harmful and can have long-term effects that are unrecognized. And of course, with concerns with, using it in pregnancy where they could potentially be an impact on mother and forming baby, right? So one thing to really emphasize here is that messenger RNA are just the codes that are genetic codes that the body reads off to produce proteins. So mRNAs make your body produce protein. So you can make mRNA for any protein that you want the body to make. And since we know that the target of the virus or so-called vaccine antigen, because if you want to target a part of the virus to prevent the infection from taking hold, you target the spike protein because that's what the virus uses to attach to cells. And that's typically the first step in infection. And so the mRNA is the code for the spike protein of the virus. It gets into the body. Your body produces the spike protein off the mRNA and it produces antibodies. This process happens in the outer part of the cell. It doesn't happen in the central part of the cell, which is what we call the nucleus, which houses the DNA. And so it doesn't even get into that compartment. mRNA is so fragile, it's out of the body in a day or two maximum following injection. So it's disintegrated very rapidly, but stays just long enough to trigger those immune responses. And so they don't alter DNA. We now have even animal data showing that they don't impact infertility. We've had many people post-vaccination get pregnant, even in the clinical trials, and they don't involve parts of the virus. So some people misinterpret the side effects they have from the vaccine as being having COVID-19, and that's totally not true. The other big platform, since AstraZeneca, for example, is used in Nigeria quite a bit, is the viral vector vaccines. Again, so what a viral vector vaccine is, usually use, let me just call it an innocent virus, okay? Or you use a virus that's not supposed to cause human disease. So for the AstraZeneca, they use a non-human primate adenovirus called the chimpanzee adenovirus. For the Johnson & Johnson vaccine, it's a human adenovirus, okay? But the virus is modified so that it cannot replicate, it can't make a copy of itself. And if a virus is to cause an infection, it should also have the capacity to replicate. So these are non-replicating vectors. And so what you do is you take that virus and then you incorporate the gene of interest. And the gene of interest here is the spike protein gene, as you can see. So where you see that little red part, if the genome is that circular structure within the virus, that little piece in the red circle is the spike protein genome, so that when you give the viral vector to an individual, the viruses are integrated and then into the host, the human cell, and then you produce the spike protein, or you just elaborate the genes that are within the viral vector vehicle. And those the protein of interest is presented to the immune system, and then you have an immune response. That's how they work. So again, because they don't replicate, they're not supposed to cause clinical disease. They don't cause COVID because they don't have the entire viral genome. It's just a piece of it for the spike protein, and they also do not alter DNA. So here's where I just wanted to mention a few things. That's the vaccine development process. This is the typical pathway for which they're done. There's studies done in animals. Studies in animals are very important to define things like we've talked about teratogenicity, which means does it affect offspring? And so, for example, the Pfizer and Moderna vaccines have both done animal studies that show that there's no impact on reproductive outcomes in animals, as well as fertility as well. The phase 1 studies help define safety. So usually you do this in very few individuals. In many of the studies are about 45, participants, that number of people. And that's where you look for safety, even before you start to use it in larger number of individuals, to do what we call immunogenicity studies, which is to assess for antibody responses to the vaccines before they even get into the large 30,000, 40,000 large-scale efficacy and safety trial. We went through all these pathways, or all through these phases of studies in the COVID-19 trials to make sure that the vaccines were found to be safe and effective. And even after the vaccines are approved, or at least receive authorization, there's safety assessments that continue to be done post. I apologize for the background noise. There's safety evaluations that go on for to assess for real world safety outcomes. So we have a vaccine adverse event reporting system. There's also a V-Safe portal for people who have been pregnant, and to monitor for pregnancy outcomes. We have almost 80,000 women in the US who have received the COVID-19 vaccine and are being followed for outcomes. And you can also do comparative studies where you can look at using 2 different vaccines, for example, to assess for their ability to protect against the virus. For example, in the UK, they are looking at a combination of messenger RNA and viral vector vaccines to assess for, what combinations work best. And so even after the vaccines have become available, there's still a lot of work going on to continue to monitor their safety. So it should bring a level of reassurance to everyone that these processes are very rigorous. There's a lot of monitoring. There's no shortcuts to really how we evaluate vaccines, and to the point where we feel comfortable to use them or utilize them in human beings. For example, these are some of the standards that the US FDA and the World Health Organization have set even before the vaccine trials were done. So even before you conduct clinical trials, we already had guidance from the regulatory authorities as to how this trial should be designed, how long they should be done, what patient populations they'd like to see, what the endpoint should be. They also, if you look at the box to the right, you can see that they also pay attention to making sure that there's satisfactory manufacturing. So sometimes it's a bit of nonsense about, one batch of vaccine going to low resource settings, such that the kind of vaccine you get in the West will be different from the one they sent to Nigeria, those conspiracy theories. But, many of these make sure there's quality control to make sure that one batch matches the other. And there was also a requirement that we had enough safety data after vaccination, up to 2 months safety data, even before they would authorize the vaccines. And that was important because they wanted to make sure that most of the reactions to vaccines happened within the first 6 to 8 weeks. And so we wanted to make sure that we had monitored people at least 8 weeks following vaccination. And this was even before the data was submitted for authorization. So for anyone that thinks things were rushed, we definitely pay attention to some of these important issues. So here's a very confusing table, which describes the efficacy reports. I'm going to break it down to you. All I just want to say is that if you look at this column where it says efficacy, you can see that these vaccines across the board have really performed very well. If there's one important variable regarding the efficacy against preventing symptomatic disease, it's the variants. And so we found, for example, the variant that was first identified in South Africa, had certain mutations that have been problematic. But even in those settings, in some cases, it hasn't really been a loss of efficacy. It's just that it has taken a hit. I think for now, the one variant vaccine combination that didn't really work so well was AstraZeneca for preventing mild to moderate disease in South Africa. However, we find that even though the vaccines may not protect against mild to moderate disease, they definitely still do protect quite significantly against having severe forms of disease and dying, so that you can at least be guaranteed that if you get any of these vaccines, that even if you got disease, that you have a high chance of not becoming seriously ill or dying. Since we've done the phase 3 trials, we've since expanded that to children. We completed enrolling in the Pfizer vaccine 12 to 15, and we just submitted data to the US FDA yesterday to request expansion of the authorization to kids. So we're going beyond adults. Studies in pregnant women are ongoing as well, which is really exciting. Real world studies. So this has been clinical trials, and sometimes clinical trials, because the kind of populations we select for clinical trials can be different from the real world. It's actually been nice now that the vaccines have been rolled out, that the real world studies are showing high efficacy. In fact, in the US, the CDC reported that even after just one dose of the vaccine, there was already an 80% protection against COVID-19. For Israel, they actually found after completion of the vaccine, even where there was the B117, as this strain first reported from UK, 97% protection against symptomatic disease, and even greater than 90% protection against even carrying the virus without symptoms, which is just amazing. So in some cases, the efficacy in the real world even looks better than the efficacy we found in the clinical trials. So here's where I just want to highlight is that you could, if you look at the table where we talk about vaccine efficacy as calibrated by COVID severity, you can see that even though the numbers may be lower for preventing all forms of symptomatic disease, mild, moderate, severe, you can see when it comes to the even most important outcomes, which are preventing severe disease and death, they're almost 100% uniformly protective against having severe disease and death, which means your chance of being vaccinated, going to the ICU, needing critical care interventions, and dying are very low. It's just amazing across the board. So just wanted to emphasize that pregnant and breastfeeding women, I'm sure this question will come up. I'm happy to address that during the Q&A, but the trials in pregnant and breastfeeding women are ongoing. They're very elegant studies, including even checking to see how much pregnant women transfer the antibodies from the vaccine to the kids, and also the impact of breastfeeding or no breastfeeding in antibody transfer. So very fascinating studies are being done to understand if vaccinated pregnant women has implications for the child, and also if there's what breastfeeding does. We're also looking at different forms of immunosuppressed patients as well. One of the questions to answer here also is why 2 doses are needed, and really arises from some of the early phase data. So immunogenicity is really just looking at the immune responses to the vaccine. So if you look at the figures on the right, where you see the arrows are the vaccine that people get. So, for example, this is the Pfizer vaccine. So people get 2 doses of the vaccine 21 days apart. And these bars represent the neutralizing titers that people develop. So you can clearly see after the first dose, after the first vaccine dose, regardless of whatever strength, you can see that the neutralizing titers do take a long time to even start to become detectable. And where you see this green line, okay, is really where you'd like to see, is really the lower limit of the antibody levels we see in people who've recovered from COVID as the bar. So you can see after the first dose, you don't even really come close to that bar or target. But when you get the second dose, a week after the second dose, you start to see the antibody levels rise across the board. And so this became obvious from the first early phase trials that the first vaccine dose was important to prime the immune system. The second one really gave you that boost that now resulted in the improved antibody responses. So in general, that's why the 2-dose vaccine have been done. I know many of you would have heard that Johnson & Johnson trialed a single-dose vaccine, but they're also now looking at the double-dose vaccine trial, and we'll wait to see what that data shows. The other important thing we noticed in the Pfizer vaccine trial was that, again, day 0 is when you get the first vaccine. Day 21 is when you get the second shot. This is in the blue is COVID-19 and people who got the placebo, so they didn't get the real vaccine. And in red are the people who got the vaccine. We found that as early as 10 days after the first dose, that you started to see the less cases of COVID-19 in the vaccinated people compared to the unvaccinated. So that even you start to have some protection after the first vaccine, but again, kind of suboptimal. So I wanted to look down here. This is the efficacy where it says percent. This is the vaccine efficacy. You can see that after dose 1, we found about an 82%, but after 7 days after dose 2, we found a 95% efficacy. So again, you see that efficacy increases after the second dose is received. One of the other important questions is, does being Black or white or anything, does being older, younger, gender, male, female, and all that. So we did look at that, and every trial looks at that. And sometimes, in some cases, older individuals, for example, could have higher protection. In some cases, older people have a little bit lower protection, but in general, gender, race, ethnicity have not stood out as determining, everybody's had the same vaccine efficacy, which has really been reassuring in spite of those characteristics. All right, so again, we've seen that same first dose, after first dose, some efficacy, after second dose, so much better. And it's been shown across, the different Sputnik is an adenovirus vector vaccine, Pfizer and Moderna, mRNA in general, they tend to do fine. So these are the safety records of the vaccine. So you know that there's 2 side effects we look for, which are local reactions to the vaccine, which can be pain and skin type reactions, but there could also be systemic side effects, which are the flu-like symptoms people can develop. Here I listed those that were grade 3 or more. So just leaving out the mild cases because the frequency should be higher. So people should reasonably expect when you get a shot to get some pain. It's not unique to the COVID-19 vaccines. Any vaccines people get, shingles vaccine, HPV, measles, mumps, rubella, any vaccine you get definitely can result in any of these symptoms. I think because we're dealing with the COVID-19 vaccines, there's a lot of hypervigilance around, oh, I had a lot of pain, or I had, these side effects following the vaccines, following the vaccine. So we found in general that these symptoms are predominantly mild to moderate. Older people actually tend to have less of those side effects than younger individuals. And in the most part, they're, non-fatal side effects. In the vaccine trials, we found, as you can see, no deaths that were related to the vaccines, okay, across Pfizer, Moderna, and Johnson & Johnson. And even for the serious adverse events, some of them were questionable as to even if they're related to the vaccine at all, for example. And then I've told you about pregnancy safety data and animal data. And like I told you, we've had almost 80,000 pregnant women in the United States get the vaccine so far, and we haven't heard of any severe events occurring. Again, pregnancies are 9 months, so we don't have all the data quite yet, but there could also be miscarriages and things, and we don't see any signal above what happens in general population as of yet. So I know many of you have heard about this, especially because AstraZeneca is a common vaccine in Nigeria. I think the important thing and the syndrome here is that people get low platelets or at least have a decrease in their platelet counts and then have bleeding or clotting events. And some of the clotting events are not the typical low extremity clots and things like that. It's kind of in unusual places like coronary sinus and visceral thrombi. So just to put a scale to it, it's really only been about 40 or so confirmed cases or less than that in 17 million people. And I think that number continues to increase every day, so that the incidence of this is 0.0006 or something, like a very small scale. So way, way, way less than a thousandth or 10,000th of a percent. Okay, encouraged. So just to keep that in scale. And frankly, if you look at the rate of some of these events, they're not really looking like they're much higher than unvaccinated people who develop these events anyway. But just yesterday, there were two important publications in the New England Journal of Medicine, one of our highest impact journals that we regard in our community. And these are reports from Europe. The first one was about 11 patients between Germany and Australia. One of the interesting things is that for these complications, it tends to be women, it tends to be younger women. So in Germany, Australia, there were 9 out of the 11 were women. In Norway, it was 4 out of 5. It tends to be younger individuals. The median age was, I think, 36. For the German Australian patients, it was between 32 and 54. And it's thought to be immune mediated. So that's something, it's possible that there's something about it that causes the platelets to get activated. Platelets are the blood cells in your body that form clots, and causing them to clot in unusual cases. And unfortunately, some of these cases, they've been fatal. We don't quite know yet. There's starting to be evidence that there may be a link to the vaccine, but the incidence rate of this is so low. And I think, again, if we do the same study on almost every vaccine we receive, I think there could potentially be a chance that we'll uncover some of these events. So the bottom line is that these cases are really, really rare and should not dissuade people from getting the vaccine. And, hopefully in the future, when we have more choice, then we can also then calibrate, which vaccines we have available. But for now, we just don't have enough vaccine, and we have to use what we have. I'm not going to go too much into this, but I think this, again, a nice connection to the former presentation, that genomic surveillance is critical because certain mutations in the virus have been associated with decreased efficacy of some treatments like monoclonal antibodies, but also the impact of have some impact on how well the vaccines work. So remember, I showed you that AstraZeneca and Johnson & Johnson had lower efficacy in South Africa. We've also found that Novavax, the protein-based subunit, also took quite a hit with regards to virologic efficacy when it came to the B1351, the South Africa variant. And I know there's a B1525 in Nigeria as well that has the 484K mutation as well. That could be a problem. So again, as each of these mutations come in, sometimes they're going to have different mutations. Now there's some concern for a recombinant event because there's now being reported strains that have mutations that have been seen in different viral lineages. So that maybe like other viruses, maybe the viral strains are exchanging their genomes. That can be very concerning from the pandemic. So as these continue to arise, you can see that there's certain mutation combinations that we still don't know too much about with regards to the vaccines. So the message here is not really to be scared about the variants, but the message here is that the sooner we get everybody vaccinated, the sooner that we take away the environment where some of these variants can emerge. So one of the reasons why vaccine hesitancy can hurt us is that as long as there continues to be circulating virus, we run the risk that this epidemic can continue to be perpetuated by emergence of new variants. And like I said, even in parts of the world where they can snuff out the epidemic in their own countries, this will be a risk for resurgence. So in some ways, as a global community, we all share the same fate depending on what the virus does in the next months. One thing I'll just mention is that one of the questions we have, and this is also quite a scientific slide, but we're finding that the T cells are one of our cells that one category of our immune cells that are able to clear virally infected cells. The point I wanted to just make here is that we're finding that even following the initial vaccinations that people get, that the T cell immunity recognizes different viruses, even those with the mutations where there have been poor neutralizing antibody activity, again, suggesting that T cells may be one way, T cell immunity from vaccines may be one way that may still offer some protection against some of the very worrisome variants. Again, just wanted to highlight here that, to achieve herd immunity, which is having enough people in the community who are vaccinated and immune to protect against the disease, continuing, that is a combination of the vaccines and also immunity from natural infection. And so, we know that to achieve herd immunity, we really need very high levels of vaccine uptake. You need about, the estimates are kind of all over the place, but I think a good range is from 60 to 80% of the population has to be immune for the virus to stop circulating. And one of the big issues that are faced are vaccine hesitancy, especially among minorities in our setting, vaccine study gaps. So again, we don't have vaccines approved for younger children yet. And again, groups like pregnant women are being concerned, and then vaccine access and distribution, right, which we know is very, very disproportionate regarding to rich and other low middle income countries. So sorry to keep this so long, but again, I think that we've seen that the clinical trials have really been important to define what works, where they work. And I think 2 doses are really important, and emphasize that for optimal efficacy. We've seen how they relate to immune responses. And I think getting the second dose also impacts how long the durability of the protection against the virus. And then we've talked about some of the strong regulatory agency oversight as a reassurance to us that the processes are this rigorous oversight over efficacy and safety. And so that we shouldn't have that impression that there were shortcuts. And again, for now, even with the variants, the vaccines do protect against severe disease and death. The Pfizer vaccine trial actually in kids showed 100% protection against the B1351 variant. So for now, I think with the vaccines we have, we're probably okay, but I worried about future variants that could impact the vaccine. So I'm going to stop here, and happy to listen, to take questions in the future. And thank you to Nigeria Magazine for having me. It's such a pleasure.